Welcome to Be Well with MS podcast, where we dive deep into the management of multiple sclerosis and explore the latest in care strategies and innovations. I'm your host, Dr. Agne Straukiene, and today we embark on this special journey through MS patient pathways, the patient-initiated follow-ups systems that, in other words, are called PIFU, and the exciting frontier of AI, artificial intelligence in healthcare, and in particular, cancer. We have the pleasure of being joined by Dr. Omar Almasri, a renowned MS neurologist from Referral Hospital. We share loads of meetings together, and I value his opinion, and we started conversation about the patient-initiated pathway. So we were in Zurich, and we're on the plane. We decided to cover this conversation in the format of the episode of Be Well with MS. So welcome to the episode, Dr. Almasri.
Oh, thank you, Agne, and thank you very much for the opportunity to speak at your podcast. As we talked on the plane, it's an immensely important topic, not just for us, but for our patients, for our institutions, and for MS healthcare going forward, really.
Absolutely, Omar. I can't strike the importance of the topic. It's not going to be an easy one to listen, I promise. We're going to slow down. We're going to use some examples and case reports and what's happening around in our day-to-day living and day-to-day as a healthcare providers. What do we experience? And what do they need to know about the taking care of themselves? How can they contribute to initiation of the follow-ups, and how can we be more innovative and advanced in the current environment? I've been inspired by one of the an article that I read from Finance Digital Future and Fixtures Technology that outlines several key points regarding the current state of technology within the NHS and the call for modernization from the West Streeting, the Shadow Health Secretary, who says that NHS is struggling with absolute technology issues, comparing to the current systems to those from 1948 rather than being ready for 2048. You see what I mean? Like, we are lagging in time, although the technology is evolving and there is a huge revolution with the AI tools these days, but we are very far behind reaching our goals. We have to rethink and advocate for more rapid and widespread adoption of modern technology and the creation of the unified access point for technological innovators, and how innovation could play the key role. And I think there are so many issues, and everyone identifies that. And the technology adoption and integration is a problem. Lack of staff from IT perspective within the NHS, and various other different disciplines that we sometimes trying very hard, but we really not quite there. And there are some pioneers which I just discovered. It's E18 Innovation, which is a cancer program. It's intelligent automation supporting the NHS to deliver on key cancer targets, such as waiting times and referrals to the treatment, by accelerating manual tasks, such as tracking patients through multiple complex pathways and managing data across clinical systems. Intelligent automation is improving clinical outcomes by enabling the NHS to see and treat patients in a more timely and more efficient manner. So the cancer services are using the tools that helps people to have earlier diagnosis, have faster results, and improve patient tracking, and have faster treatments and faster treatment time. And there is a prediction that 75% of cases who are being diagnosed at stage 1 and 2 are going to be diagnosed in a much more rapid way by 2028, using the technology robotics, AI, machine learning, all these fancy things that we hear a lot these days, but it gives a key benefit, such as transforms the patient care, reduces the referral backlog, improves waiting list management, reduces clinical risk, enhances data quality. And when we have an accurate measurement of the human being and all their markers and biomarkers and the structure changes, we know how can we best help and start the medicine in a very timely manner. So with that, I would like to bring it into the conversation, Omar, and I would like to know what is the overall overview of MS and its typical patient pathway? What do we do day to day?
No, thank you. I think you hit the nail on the head with your introduction. We're transforming technology to suit the way we used to think in 1948, as you said. And so it's not really transformative, whereas what we need to do is transform the way that we think about how we approach patients, how we approach management. In my view, the current situation of patient referral and review, which is based on either a GP or a colleague seeing a patient and then referring them through to a clinic appointment so they get triaged through reading of the letter and then deciding on seeing them in an urgent slot or a regular slot, and then deciding from there on management strategies, then reviewing them after that, and then delivering a diagnosis, not only is less efficient, but also increases the anxiety that I see our patients go through. Having that ambiguity about what they're there to discuss or what the appointment is about, and then being left in limbo, saying that we'll do these tests, and then at the end of it, you might have a diagnosis delivered that is life-altering, or it might turn out to be a simpler version of it, such as clinically isolated syndrome. It could be something else, or it could be nothing. The level of ambiguity is quite significant. And so one step towards the innovative approach is flipping that model on its head, where there's front-loading of tests at the point of first recognition of a problem. So a patient is identified through their GP service or through a colleague or through an incidental finding with a test to have an inflammatory condition, mainly MS, as you know, because it's the most common of these conditions. They go through a process of contact, management, decision, and then meet up in clinic. And the detail of that headline is a patient is streamlined through a referral process from a GP through which they get a triage of their referral. A plan is set for blood tests, imaging, CSF analysis or lumbar puncture or a spinal tap if necessary, or what we call evoked potential testing to measure the speed of conduction through the central nervous system, plus minus other tests relevant to that person themselves, using the time that it takes from the referral point to being seen in clinic to front load these tests, and with a bit of an introduction from the neuroinflammatory team or the team involved in MS, saying that you are on our radar, you've been referred for this sort of problem, this is the investigation, and then having an open discussion at an appointment that is long enough to accommodate that discussion, that important moment in somebody's life, and then taking that extra step forward with either a diagnosis, no diagnosis, or further testing. I think that's probably a very good first step. Having more information disseminated into general practice, having upskilling of people who are seeing patients for the first time, our GP colleagues, our emergency physician colleagues, now our physiotherapist, pharmacist colleagues even, upskilling those people in what to look for when looking for neuroinflammatory diseases. Most problems, you can reassure somebody that they haven't got anything serious going on. But there are some key points that would make you really want to investigate that person a bit further. And recognition early means that they get to treatment early if that is deemed necessary. And therefore, you've saved them time and you've saved them brain by having that streamlined process. It'd be quite nice to see what your experience is, Agne, because I know you've had a very innovative approach yourself.
Yes, Omar. So I think that the current pathways that we've got in place, and we sort of we take this example as patient is coming from GP surgery, but there are so many other pathways that people are being referred to our clinics, to our MS services. You know, whether it's coming from colleague, whether it's coming from maybe inpatient, another specialties such as quite often we get referrals from rheumatology, hematology, oncology, colleagues that refer people to us. And I think there is overall, if you look at the whole process from the bird's eyes, you know, there is a huge delay. You know, by the time people hit our MS clinics, you know, there is at least, you know, a few months. And if once we start the process and pathway of initiation of the diagnostics, that's another 6 to 10 weeks of getting the results back and making the conclusion and making the diagnosis. So I think we have to find the way where we intervene in the timely manner, where we can shorten the period of time from the referral down to the patient seeing in MS clinics. So recently I made a decision, and I ask and encourage my colleagues when they are referring the suspected MS cases, they do some initial baseline investigations. And the first of all, the very basic is MRI scan of the brain, or MRI scan of the brain and spinal cord. I know that some of the GP doctors are not able to request both scans. They can only do the MRI brain. And the same rule applies to my colleagues if they are referring from the neurology clinic. So some basic investigations such as lumbar puncture, looking for oligoclonal bands, neurofilament level, MRI scan of the spine and brain. These are sort of essential key diagnostics that needs to be done. And then there is the whole sort of a GP system that we call this advice and guidance system, that we advise primary care physicians in terms of what investigations, what is working diagnosed, what expected outcome is going to be, or what the test that we are going to require to arrange in the future or tomorrow, for example, depends on how urgent the clinical cases are. But if there is a suspicion of demyelinating process or MS, we always say these days to the GP doctor, please arrange an MRI scan of the brain, and then thereafter we'll see the patient, because it saves a few more appointments. And then from the MRI scan, we can move on to more invasive procedures such as a lumbar puncture. So I think the communication is the key. But I think there are so many ways of getting it even better. You know, some sort of identification and using, the AI to identify the patients in the normal population and cohort with the prodromal symptoms, and looking at the behaviors of the hospital admissions and ED attendances, you know, whether that could draw a pattern that we could deploy the machine, identify these people who are just about to develop MS, but they don't know that as yet because they are still under primary care, and speed up that sort of process of triaging and referral to the specialist clinic, such as MS clinic.
Yeah, I think so. I agree. And part of the question in my head is about people's ability to describe their symptoms. As you know, we both work in the Southwest, and we've got a very stoic population that doesn't complain of much, really, unless it's a significant problem. And most of it, it can be a bit difficult to describe the symptoms in a certain way that elicits those key words that would ping your GPs up, or ping the neurologist's ears up, saying, actually, this patient might have something like MS or a demyelinating problem. And developing an algorithm or an artificial intelligence system that would be able to pick out the patterns, the behaviors, as you say, the prodrome, that slightly opaque beast that we don't quite have defined yet would be immensely helpful for that cohort as well. I think you're absolutely right. Having an innovative approach to try and shrink down the time from start of symptoms to an accurate and clear diagnosis would be quite helpful. The difficulty lies in having the steps in between streamlined. What I find is that there is an infrastructure that needs to coexist with the usual service to try and smooth that process. For example, if a GP refers a patient and they have organized the MRI scan of the brain, they're less capable of organizing the specialist blood test that we ask for example, such as aquaporin 4 or MUG antibody testing, not because they're incapable of interpreting these results. These are very experienced colleagues, but it is our field of expertise. It is our bag of work. And so we are the ones expected to take on that work. And so having a carved out bit of time for the neurologist, for the specialist to be able to say, actually, this person needs so-and-so tests, and therefore that will enable me to see them in clinic in a timely fashion. As you say, testing takes about 6 to 10 weeks, and you've shrunk that time from the point of referral to seeing the patient with usable results, with tangible data that you could have a discussion on, rather than just a story, examination, and a lot of maybes. I think that's quite helpful. It might be a little bit out there, but also I feel people's education, like we do for things like stroke, giving very simple headlines, principles, that these are problems that we would like to know about. Yes, it's asking for more work at a time when the NHS is struggling. That's to be accurate about it. Mm-hmm. But at the same time, it means that people are empowered to recognize, understand, and act on the presence of symptoms and signs. People know their bodies. People have lived with their bodies. They understand what's normal, what's not normal. What they need guidance on is what it is, what to do about it, and what the future holds. And I think enabling them to have enough information to raise the question outright is very important. We see it sometimes with patients who are well informed about multiple sclerosis, either through family or through reading or through other resources, where they go point blank to their GP or to their neurologist or to the nurse's department saying, have I got it or haven't I got it? These are my symptoms. I've looked these up and it seems like there is something here. And I find that quite helpful for a discussion because it means that we've actually gone past the initial bit of trying to define what a patient, what somebody's worried about and how you could approach that and dive into their symptoms. In most cases, as you know, these might not turn out to be multiple sclerosis or any concerning problem, but it is a symptom of concern for that person. And having that ability to have an open discussion with them, I find is refreshing.
Yeah. And I think we need to sort of brainstorm a little bit today about what are the key words that would be a red flag for numerous amount of the specialties that refer MS patients to us, and maybe GP and family doctors, that they would identify that as, okay, this is more than migraine. This is more than fibromyalgia. And I think my first sort of insight would be, if somebody presents with a tingling sensation, plus minus headaches, and bladder and bowel involvement, for me as neurologist, as MS neurologist, I would always think, okay, this is too much for the fibromyalgia or a migraine, to have a pelvis function involved, having patient who's incontinent or has got some retention of the urine, right? What would be your sort of the key words that it would be sort of ping pongs, like, okay, this is too much now. It's just not, it might have some flavors and some sort of features and patterns and, you know, of MS. What would it be for you?
Yeah. No, you're absolutely right. I think bowel and bladder involvement is definitely right up there, because you're talking about young people who you don't expect to have pelvic floor problems. You don't expect to have prostate problems attached. And the presence of symptoms over a period of time, having that odd tingle or odd symptom lasting for seconds or minutes, may not be in and of itself an issue to take forward. But when somebody's complaining of an episode of tingling or an ache and heaviness in an arm that persisted for a few weeks, which is then improved, you think that time duration for me is a bit of a red flag.
Yeah.
Having symptoms of a neurological flavor in a youngster in general, for me, I think is a bit of a red flag. And by neurological flavor, I mean that clumsiness, that difficulty to describe. Oftentimes people say that they drop objects. That is not very specific, but you find when you tease out a bit more information, that there's that clumsiness story. There is that my arm is not doing what I want it to do story. And again, it comes with that timeline. I also find that people's description of their visual symptoms fascinating, not only because what people see and what we think we see is completely might not be the same thing, but also how people perceive their symptoms is just mind-boggling. A person who might be experiencing an episode of demyelination might focus on the ache in the eye, and that might be labeled as a migrainous headache. But in reality, if taking a bit more of that story, such as the detail of how that aches, looking at whether or not the visual function has been impeded, I find those are reasonable flags. So for me, a person who starts to complain of neurological symptoms out of the blue when they haven't in the past, especially when it comes to things like headache, as you say, I think is a significant issue. People who have been complaining of duration of symptoms that lasts for beyond that few minutes or within more than 24 hours, again, for me, I don't find appealing for a migraine phenomenon at all. People who are complaining of bowel and bladder symptoms, and people who are complaining of this difficulty with walking or coordination or balance or clumsiness that they find a little bit more difficult to pin down, I think it would be very reasonable to take forward.
Just going to intervene a little bit here. And I would like to ask the cognitive issues plays a key role, So these people who come and say, I was not able to perform at school. I always forgetful. I always clumsy. I can't remember. My family members are highlighting that I asked this multiple times. The memory, the short-term memory is also a red flag.
Yeah, absolutely. And even as you know, people complain of this. It's harder for me to think through a problem than it used to be, or it's harder for me to do it than others, or this brain fog, or this difficulty getting through the information that's being delivered. I think that's probably an underrepresented symptom that gets brushed under the carpet of fatigue or general ailment, or that's how it's been such a problem. I think you also hit on a key point of people who have complained of symptoms or who have had symptoms but not necessarily complained of them in their teenage years. I mean, I don't know how often you see this, but I see it not too infrequently, where somebody would go, oh yes, well, I've had this for a few months when I was a teenager, but then nothing came of it and I got better. And you think, well, that probably was something I would have done something about, except as a teenager, your body's ability to compensate for any sort of problem would make it so difficult to recognize any signs on examination. And it's all in the story. And I think one of the other issues, and this might be diverging a little bit from the keywords or key points, is having enough time to allow the person in front of you to say what they want to say in clinic or another environment. I think that's probably as important as having the key words, is allowing them enough time to try and explain what they're trying to say. People have different speeds of getting what they want said out, especially if they're experienced at it. They're usually experienced at getting on with things. I find that probably as important, really.
Very much so. And I think overall, if you look at the whole sort of community of multiple sclerosis, all the charities, they do the great job and educate people. The awareness of MS is huge. We get referrals, people with normal MRI scans, normal blood results, normal lumbar puncture results sometimes. The reason why they undergo lumbar punctures is probably for certain onset of headaches, and somebody decides to add the oligoclonal bands into the CSF as part of the screening for possible neuroinflammatory disorders, given the symptoms. It's sort of secondary working diagnosis, possible demyelination. The awareness is huge, and some people are being referred as possible MS, and they end up in not having this diagnosis, but they suffer. They have something going on in their lives and in their bodies and minds, etc., etc. So probably it's fibromyalgia, probably it's something that is not related to multiple sclerosis, because normal MRI scan cannot be present in people living with MS. I never met anybody with MS who's got normal MRI of the brain and spinal cord. So I think sometimes we go into sort of from one deviation from not reporting, under-reporting, lack of the language to describe, some denial element, getting into the services and getting specialists to be seen, from having a huge hyper-alertness with a functional neurological disorder flavor and spectrum, into sort of a huge media influence on, MS as a highly prevalent disease, and everyone can develop this at any age. Peak age is 40, although it's now, and people with MS who are newly diagnosed are coming to our services at age 60 and 70. It's aging. The MS, because the lifespan is expanding, and it's, people in 50s, 60s, and 70s, they have the similar lifestyle as they had when they were 40s. And hence, I guess there is a bit of element of the delay in diagnosis and the onset of the diagnosis at age 60 and 70. It doesn't surprise me at all. Like every other person are being diagnosed at age 70. So I think, the way the stroke specialty is educating society and community is, look at the mirror, see whether your face is symmetric, asymmetric, stretch your arms in front of you. Is it drifting down or not? We haven't got tools or some sort of education or quick screening for people with MS, because of the variety of different symptoms and all these red flags that we just listed. It could be one or two things that are present in your case, but maybe it's variety from, some weakness, balance, coordination, clumsiness, cognitive issues, bladder and bowel problems. It could be it's a blooming combo of all these symptoms, and that's even more concerning. But, so I think that the complexity is so it comes as a hyper alertness and awareness of the condition, which never is being confirmed. That upsets a lot of people, because they can't find the resolution, they can't find the answers while they're feeling so unwell. There are a category of people that are in real denial, so it's difficult to get engagement, get to know them. You see them once, that they disappear from the services, they never engage back to you, and never come back for the follow-ups, etc. And then there are people who gets into the system, they get into the system 10 years later from the onset of their symptoms, and then they wait another 10 weeks to get the lumbar puncture, to get evoked potential, because in the current NHS environment there is a huge delay. So I think we go back into sort of how can we best identify and work with people who are willing to work with us.
Yeah, I think that's the key word, willing to work with us. The reality is, people who end up not having a diagnosis of MS, it all boils down to the communication, the openness of what is going on. Being told that it is a non-diagnosis, that there are symptoms, that they are definite symptoms, and the patient has been describing very real symptoms, but that we do not know what's causing them at this point in time, and that we're using time itself as a test, I think is as honest an answer as I could give some patients. a positive diagnosis of functional neurological deficit, I don't find is something that I would shy away from, because it means that this person has had a problem. It's like diagnosing migraine. It is a real problem. I don't have a scan to show them that they've got migraines, but they have a problem, and it has a pathway of management. There is a treatment pathway. I think my issue with fibromyalgia is that there is a clear diagnostic criteria based on I think it was the American Rheumatological Society, if I'm not mistaken. I think the name is different, but also it has been adopted by the Royal College of Physicians in London. And it does require a bit of an expert hand to navigate the symptoms. And it is a pain syndrome. It can coexist with other problems. It may very well coexist with a number of people who have got MS. Again, that is a positive diagnosis. I would agree with you. I think the main issue comes from people who have had the time with symptoms, with a normal scan, definite symptoms of tingling, numbness, slightly difficult to describe symptoms. They wait between the time they've seen their GP, then to see a neurologist, a number of months down the line. At the end of that journey, they feel shortchanged when they're told, well, I don't think there's anything wrong here. And it boils down, again, to communicating with that person saying, I'm sorry, the tests look fine to the resolution that we've done them. As you say, when it gets to a point where somebody has had lumbar puncture done because a scan, even though it was normal, might be not normal when it was reviewed by different pair of eyes or looked at from a different angle. By angle, I mean metaphorical angle, not kind of angling scans, as you know. If a lumbar puncture is normal, the scan is normal, the blood tests don't reveal an alternative pathology, it does not take away the existence of symptoms for that person. It just means that at that point in time, we have not established a clear diagnosis for that person, that we're using time as part of that testing process. And I find the clarity in the communication and discussion saying that we don't know is probably, for me, slightly more, well, is better. I wouldn't necessarily say more honest, because we're always honest with our patients, but it is slightly better and more upfront. And I find that I have better resolution with patients and better relationships with patients when you've been completely open about what you've seen with them. I think people who are in denial are a slightly varied kettle, because you have people whose livelihoods depend on them not having a diagnosis because they're self-employed, or they're just picking up a job somewhere that does not accept people who have got something like MS. There are people who are scared of this diagnosis because it is a life-altering issue, even though the treatments, the management at this day and age mean that there is a significant change from the natural history that has been taught in our times in medical school. And there are people who feel that the treatments and the management that we do are quite invasive, and they feel that engagement from the medical profession, for one reason or another, does not have their confidence in us taking those decisions with them. And I say with them because ultimately they are our partners in this. To try and sort of filter out some of these, or to try and salvage as much of these people who we think might benefit from, if not treatment, at least being on our radars or monitoring, I think that engagement with people's healthcare providers is one way to try and bridge that gap of care for people who have problems, who need that support, either of being on our radars or needing treatment, and also bridging that gap with people who have got symptoms, but whose neurological investigation and testing do not show a primary neurological cause for their underlying complaint. I find that engaging with societies who are doing marvelous work to try and educate people about MS and other neuroinflammatory diseases. To be honest, you find some of those on the other websites, such as optic neuritis or clinically isolated syndrome, is fantastic, but also having some clinician presence or ability to access things like this podcast, where people could have some insight, some knowledge of what we can do, what we are doing, and that it is much easier to ask a question than worry about it. I'm very happy to try to see somebody who's worried about something like MS, and as I'm sure is any neurologist in the country, with symptoms that are concerning for the problem, and then deciding with them whether we think what the best plan is and whether we would take this forward or not, and why we don't think they have MS, or why we think they've got a need for monitoring, or why they indeed do have the condition.
That's very comprehensive insight, and thank you for that. And I can only echo and go into sort of a bit of a brainstorming and out-of-the-box thinking here. In ideal world, the way I see the world, for the newly diagnosed or people who are not yet diagnosed, I think we need to do a great analysis with a current cohort of patients and educate AI to identify the patterns of the symptoms, of the diagnostics, of frequent visits to the GP, of the conversations that GP and family doctors and the patients have. All needs to be recorded in a metadata type of and securely saved information, that the algorithms could be developed to identify these patients who are at most risk. And then once we establish the machine learning and algorithms, we can deploy that within the primary care or helplines, that comes via charities, that the algorithm could identify the red flags, the patient at most risk, and triage them in an automated way and a speedy way, depends on the clinical situation, to the MS service within 4 weeks, let's say. Let's set that sort of goal. And then the rest of the diagnostics in that sort of waiting time, 4 weeks to be seen by the MS specialist, the diagnostics tests could also be implemented in place, such as lumbar punctures, such as MRI scans, etc., that the consultant neurologist with a special interest in MS could make that clever, smart decision that is game-changing, life-changing, and preserving the brain health.
Yeah. No, I fully agree. The elephant in the room might be that people feel one of two things: either that they've been excluded because the algorithm hasn't necessarily picked them up, but as you say, this is a process that is improving over time, and it's just to enhance the existing structures. This is not a replacement for the current structure in its current form. And the other issue would be around the over-investigation of people who may not have necessarily relevant or correct symptoms, but who have been identified, and if they develop complications as a result of the testing. And I think my comebacks on both of these points would be: the current systems rely very much on people's eloquence to try and describe their symptoms in ways that will make us understand what they've got, and rely on them making that contact with the correct services for the correct amount of time for that to translate into a referral or an appointment or being put on the radar of a neuroinflammatory service. And so something like artificial intelligence driven or machine learning driven algorithm that would allow pattern recognition of people in this prodrome, where we know people have more contact with healthcare providers, we know people have got non-specific illnesses, we know that they have a certain demographic, which does include a certain number of illnesses in the background being made or diagnosed in the lead up eventually to a diagnosis of multiple sclerosis, I think would be immensely helpful. And it is that helpful, not substitutive of the current situation.
Just to enhance the process.
Yeah,
and imagine if we deploy the augmented reality, and the augmented reality is able to process the natural language, read the facial expression, pick up on something that is is body language, not non-spoken body language. And add that sort of enhance that sort of understanding of that human being and human brain, and highlight the issues, and then make that referral straight away. I think this is where we're going to win and preserve the brain health. And in a way, MS may have less damage to the brain health, if we identify at the very, very early stage, because all these treatments, disease-modifying therapies, only work if you start it in the very early days of the MS diagnosis. The later you come with the powerful drugs that we have developed, the less effective they are. The potency drops down, and there is loads of research to cover that.
Yeah, no, I agree. I think this is very similar to, or one of the examples that I use to bring this a bit closer to people's minds is what we call gut instinct. People develop gut instinct over time of doing certain jobs. They develop a gut instinct for what they think is right for a particular person. But it is exactly that. Our brains process more than we recognize, and more than we know, more than we're able to articulate. And so I would not be put off by that idea of having recognition of things that we don't necessarily perceive as hardcore facts relating to multiple sclerosis or patients' hard examination signs, such as an upcoming plantar. I think you said two marvelous points. You said about using AI to enhance that understanding of the diagnostics, and you said about the earlier treatment translating to better outcome for patients. And absolutely, there is a whole raft of data, a whole raft of studies that supports that. And I think another important point is getting to the bottom of what causes MS, what MS is, hinges on defining the problem early, because we're seeing a common pathway between probably slightly different processes, where eventually we see a typical presentation of what we call MS, whereas understanding the beginning of that story, I think, is still difficult. And I think recognizing patients at the earlier stages means that we have better chance of defining what happened to them closer to that time, or what's different about this group of people that made them more vulnerable to this problem. So I think it's important for now and for the futures. And I totally agree with you.
Yeah. Moving on to more established diagnosis. So imagine that we have people who we follow on the regular basis. And we, according to the NICE guidelines, we have to provide a comprehensive review annually. But the new innovative way, the way your trust and my trust is looking into, is moving on to patient-initiated follow-ups. Can you explain how this system benefits MS care? And do you have any real-world experience at your hospital that are already using the PIFU? And how does that work? Is it realistic? Is it something that can be done easily? Or what are the pitfalls and cons and pros having this system in place at the MS service?
No, sure. So patient-initiated follow-up is exactly what it says. A patient who is under follow-up by a particular service, as in they are on the list of people that service knows about and looks after, has the opportunity to initiate their follow-up appointment or make contact with the service to book an appointment to be seen in clinic based on certain parameters. In the context of multiple sclerosis, I find that people who are best aligned with this sort of follow-up are those who have had stability in their clinical symptoms, stability in their EDSS, the Expanded Disability Scoring System, and stability in their imaging. And so reasonably, we can make the assumption that their multiple sclerosis is stable. I would add two more layers to that. People who have had immune reconstituting treatments such as alemtuzumab or cladribine, people who have had treatments that don't require continuous top-up of that treatment and have had these other parameters met, where they've been stable for a period of time, who don't necessarily require input from us at random intervals, when they are quite well, I think would be better suited for something like patient-initiated follow-up. And I appreciate the numbers are variable in different trusts for this sort of cohort. People who have what we call clinically isolated syndrome and who are well educated about the potential symptoms and signs to look out for, and who have had stability probably in radiology over 1 or 2 years, and by definition, stability of symptoms, I think would be also in a good position to go on that list. People who have had symptoms and a slightly ambiguous but stable diagnosis, and by that I mean they've got some features that could do for multiple sclerosis, but an ambiguous lumbar puncture, absence of symptoms, and who have stability in their radiology over time, I think also are reasonable for that sort of list. The reason for having something like patient-initiated follow-up is that we recognize that there is an inequality in the provision of services for people with multiple sclerosis relative to the population. And this is not because of lack of investment, but there are less people around that are able to do or to look after people with MS and who have that as part of their work, day-to-day work. And so to have the ability to see the right people or the right person at the right time in the right environment, creating some space by having people who are stable, not completely off the books of a service, but also not on a regular random follow-up where the person who has the symptom doesn't have an actual problem and therefore does not need to come and see the physician looking after them and feels that that is a cumbersome appointment. The physician is short on appointments, time. It makes it much more fluid. For that system to work correctly, I find that clear lines of communication need to be present. So a person who is advised that when they initiate contact, they will be contacted within 6 weeks with a date for an appointment, they need to have that promise delivered. They need to be able to ring up a number, make an appointment, have contact within 6 weeks to say that you've got an appointment coming up to discuss whatever it is. What I find patient-initiated follow-up is not useful for, and in my view should not be used for, is people with acute relapses, where the timeline of making contact with that acute service or that service that delivers that patient-initiated contact is going to take a long time. Whereas if the person sought contact with the, in our hospital, acute neurology service, or through their GP with the GP advice line, they would be seen in what we used to call the admission avoidance clinic or the ambulatory assessment pathway much quicker than they would have gone to their usual appointment. And the difference between the two is the acuity or the type of symptom that a person has. If a person has a symptom concerning for what we call a relapse, so existing or new neurological symptom with significant worsening outside the context of a cause for that worsening, such as a viral illness or a bacterial illness or excessive fatigue or lack of sleep, where there's concern about a relapse, I think they need to be seen urgently. Somebody who has some questions or some ambiguities about possible symptoms or minor problems that are not necessarily impeding their life, but which require a bit more attention, there is less need for them to go and book an appointment through the GP services, to go through the whole story again before they get referred, but they could just dovetail into our follow-up arrangements. For that to happen, it needs enough clinic space, it needs enough people who are well-versed with triaging if they get that contact saying, this person actually needs an urgent appointment. I don't think patient-initiated follow-up is suitable for them when they made the contact. And having some buy-in from people on that list with a promise that if they develop symptoms, they will make contact. So having that engagement from our patient partners is quite important. In Plymouth, we have patient-initiated follow-up, for our general neurology patients, as well as for our patients with multiple sclerosis. For example, a patient with epilepsy who's stable, who has not had a seizure for a predefined period of time, it is very reasonable for them to be on a patient-initiated follow-up list where they make contact if they have questions or queries about their treatments, or if they're worried that there is a further seizure that requires further action. I try to employ the system in the way I described for our MS patients or our neuroinflammatory patients. I find the pitfalls are when people make contact with a service, they sometimes struggle to get to the right person to make the booking. And I find that an unsatisfactory outcome for both me and the patient, because I feel that the infrastructure could do with some improvement in that context. And it's very useful to have that feedback so that we could improve on it. We try to streamline people who require more urgent input through contact with either the nursing team, the GP services, or the acute services such as 111 or 999, by having an additional contact to the MS service saying, I've made contact with these people because of this problem, and the outcome is this, or there is no outcome yet, could you please advise? I find that quite helpful. But what I worry about is that patient-initiated contact might be misconstrued as an alternative to emergency services. And at this present moment, there is not the infrastructure to allow that to happen. It might be something that we could look at in the future to try and reduce the number of admissions or contacts with the emergency department or non-MS specialist services for an MS problem, but probably not just yet, not with the infrastructure that we have in place at the moment, including the staff working in the MS service.
Let me bring you into the future then. The way I envision this working nicely is, again, I think that AI-based or machine learning-based doctor assistants that could coordinate the existing patient pathways, such as, I think if we had a check-in service 3 days to 2 weeks prior to the clinical appointment, patient has their prompts, patient-reported outcome measures done. So that involves looking at the patient symptoms, one of the commonly used questionnaire, your MS questionnaire, that tackles and defines all the separate different domains of the patient's reported symptoms. That's one of the examples, looking at the emotional well-being, HAD scale, and anxiety and depression scale, maybe using the wearable devices for the passive data collection. So getting to know that human being prior to coming to the appointments, I think would be a good idea. So once we have patient in the waiting area, we do various different other assessments using apps, using cognitive assessment tools, emotions again, motor, speech, language, facial expression, identifying those body non-spoken language and features that could identify people who are at most risk and who will require to be selected into the regular, continuous management and follow-up, comprehensive follow-ups at the defined pattern that computer would suggest, or whether this patient could easily go into the continuous self-management and PIFU pathway, that we have a good understanding that this is identified person that best fits the PIFU pathway. That's it. And we could be reassured that all the pressure and anxieties and that worries that we have, that they may slip through the net and never come back, or they assume they are good and they report that they are good, there are no problems, but they might be in the denial. And all the subtle patterns and features and signs that could be picked by using the technology and neurological assessment as well. And when the patient hits the MS-MDT clinic, the clinics needs to be set up with MS neurologists, MS nurse, physio at present, occupational therapists, neuropsychologists, pharmacists, patient representative, a champion patient who could support this person who's coming to see, and also women's health specialists,
Yeah.
planning the pregnancy, preconception, conception. How can we best manage with the disease-modifying therapy to reduce the rebound effect 3 months later after giving birth? What strategies do we need to implement before women become pregnant, etc., etc. And then looking at the passive data monitoring of that person's attendance to the primary care, ED, hospital admissions, then algorithms could identify the frequency of these events. This is recorded as an event, and it comes into the whole algorithm, which then categorizes people who are at most risk, medium risk, low risk, and the low risk category probably would be put on the PIFU pathway. That's how ideal world should work. At the moment we are very vulnerable as a clinicians providing this care and allowing people to be on the PIFU. But the future will be different. I would like to believe that it's really going to pick up the subtle things that we can't identify because of our capacity, because our brain is not trained enough to create the algorithms and produce an outcomes of the big data meta-analysis. We are not capable, but I think enhancing that care and identifying people, only machine learning or AI could help us to produce these robust, smart decisions that suits individual person. And learning from the role of AI in cancer service, today it's a pivot briefly and explore how adjacent field where AI makes a difference and makes waves in the cancer services. The advancements here are not just remarkable, they are inspirational too for us working in MS and for people with MS who are just about to go on the PIFU. AI in oncology is redefining early detection. It's applying complex algorithms that sift through medical images, spotting anomalies that could be early signs of cancer for quicker and more often accurate, more accurate than the human eye diagnosis. And imagine applying the same precision to the MRI scans we routinely perform for MS patients. AI analytical system could potentially detect nuances in disease progression, predict the relapses and the likelihood of the relapse, maybe tailor the treatment regimes based on the deep learning from vast data sets. For the AI, you have to have a massive data, and the AI needs to learn about the human being brain first. And I think the current system we have is not robust enough. And that could harness the predictive insights that traditional methods might be missing. And when it comes to PIFU, AI impact could be transformative. We could leverage AI to automated symptom triage, as we discuss, efficiently directing our attention to the patient's most immediate need. And furthermore, AI could refine our follow-up schedules, creating a personalized care timetable based on each patient's unique disease profile. It's a step towards a more individualized and patient-centric care model. And as we move towards more comprehensive annual reviews, AI could be our sort of ally aggregating data, offering analytics-driven insights, and ensuring that when we do sit down to review patients' journey over the year, we are equipped with a full AI-enriched picture. We know everything. This facilitates dynamic treatment plan and responsive to the patient's current needs. We would know whether this patient is going to respond to the offer or not. I think it's our focus in MS, and I think that's what we do currently. We are collecting basics. I think once we have a robust electronic records, and some of the services already have it, and going outside the UK, Germany, for example, Nordic countries, So I think the foundation is there. I think, and it's coming. It's our near future, where AI doesn't replace the human touch, but empowers it and ensures that every patient receives the best care they need when they need it.
Yeah. I think that's very much a key point here, that it enhances and enriches, and it's all about the person in the middle of this who has this neuroinflammatory condition, or for the majority of these people, for our patients or our partners, it is multiple sclerosis. I think something like using AI algorithms is enhancing the way of thinking. Remember, we started the conversation by saying that we're using technology to make how we work easier, but the way we work is applicable to an older model of healthcare delivery. And so what you're discussing now is using the large-scale data to try and personalize medicine to our patients. We are trying to do that, what we call evidence-based medicine. But evidence-based medicine is limited in its scope and resource and pattern recognition because it is driven by us and our processing capacity. That is not to say that AI is more intelligent than we are, but it is intelligent in a different way that enhances our work and our action and frees up our time and our thinking ability to work on the bigger problems. When I get a data set from artificial intelligence, hopefully in the near future, saying this person has a pattern of a scan that would suggest, even though they've got a low lesion load, they're likely to have a worse prognosis based on A, B, C. And then you add in their demographics, you add in some of their genetic profile, you add in some of their phenotypic attributes, you add in some of their biochemical subtleties, where you see things like, for example, their vitamin D level is in the insufficient rather than deficient range. We haven't really dived into that level of fine-tuning. And you add in then the complexity of their situation in their environment, in their postcode. You add in all of this together, and then you come in with a much more tailored plan for that person, saying, actually, we think this drug suits you best, even though it carries significant side effect profile because A, B, and C. And another person, you could equally say that actually you benefit from platform therapies and you'd be saving your trust money. So it is kind of, I think there are immense benefits to it. I'm not blind to some of the limitations, some difficulties, and some of the ambiguities about machine learning. We don't quite know what happens with deep learning, but we know that the outcome tends to correlate with the input, but we don't know why, we don't know how. And I think over time, that will be unpacked, and I think it will be enhanced. So I wouldn't necessarily shy away from it. And I would, again, agree with you once more on AI being a very helpful physician associate, I suppose, or an enhancement to a physician's role, but not a substitute for the clinician sat in a chair, be it a doctor, a physician associate, a pharmacist, a nurse, a physiotherapist, an occupational therapist, a clinician working with MS. This is not a replacement for them. This is another tool in their quiver that they could actually use to enhance their patient experience.
I think we need a clear objectives and vision, establishing well-defined goals for what the automation is intended to achieve, align with the strategic priorities. Are we aiming to maximize the capacity across the system? Are we developing strategic partnerships between the other services? Are we transforming the patient's care, identifying early, starting medicine early, reducing the referral backlog? Maybe we want to improve the waitlist management, reduce the clinical risk, enhance the data quality, increase the workforce capacity or capability. And everything has got a knock-on effect on the leadership and stakeholder engagement, having dedicated leaders and involving in stakeholders like healthcare professionals and IT staff to ensure the smooth implementation and adoption. It's not feasible in this current environment that we're struggling with the workforce at the moment. And also very important, robust governance and compliance, setting up governance structure for clear communication, risk management, and adherence to data protection, where the data is going to be stored, and what are the industry standards? How can we select the right technology, assessing needs to choosing the scalability and scalable devices and technology, and also it needs to be very much user-friendly technology that can be integrated within the current systems. it's a data-driven decision-making process. Of course, when you have AI tools in place and it's real-time data that helps you to make the decisions, and it's really important that patient is at the center. It's a patient-centric approach, keeping patient at the forefront. It's enhancing the patient experience, not trying to replace anything or use the sort of a system that would put the patient aside rather than in front. And it's continuous monitoring and improvement, regular evaluation and of the performance to ensure that we are in alignment with goals, and we adopt the technology, and there is a healthcare demand, and measure the return of the investment, because it costs a lot of money. Quantifying financial and non-financial benefits to provide the transparency and accountability is the key when we talk about the innovations within the NHS, and we go back into the comparing the current system to those from 1948 rather than 2048.
Yeah, no, I completely agree. I think the vision is accurate diagnosis for the patients, correct diagnosis for the sort of problem that they've come in with, and tailored treatment that would give them the best benefit and minimize any impact on the day-to-day life. I think it is a bit of an aspirational model, but if we don't aspire, we don't achieve. So we have to, I think that for me is the vision. And as you say, implementing that vision will have lots of streams to try and follow on from there. So I envisage this will be a big piece of work, and I would not be surprised for the NHS Digital to have a sister group, NHS AI, at some point. And then for that to have dovetailed work with services or with specialities or subspecialties or commissioners to try and produce the work that you've just described. I think it is immensely important. It is coming. It is present in other fields of science, of engineering, of innovation, in art. Why not in medicine? I think the value from it is something that we may not immediately touch or see, but I think it is something that is to the benefit of our patients.
Absolutely. And I think the AI role in MS is one of the most exciting developments on the horizon.
Yeah, no, I agree.
The most exciting. Well, we've covered some groundbreaking topics today. Thank you for sharing your expertise and insights on MS care and the potential of AI in MS field. Anything to add or comment? Any other information that we would needed to cover today?
I thank you again for the opportunity to speak, and it's been an absolute pleasure speaking on your podcast today. I think in terms of what we need to cover, well, there's lots of ground. There's patient impact. I don't know how we're going to quantify that with things like AI, our ability to try and streamline our services. I think we're still not very good at recognizing what people want. We recognize what people need, but we don't recognize as well what people actually want. We think we know, and I hope that we do know, but I don't know that we do know. I think that's one bit that we haven't quite covered, and I don't know that how we would capture that through a patient pathway, or how a patient-initiated follow-up would look for that sort of question, and how AI would be able to help bridge the difficulties that we currently have in our patients trying to make contact with us, or us trying to do what we think is right for our patients, and ultimately keeping people well for as long as possible with minimal impact on their day-to-day life.
Yeah. we probably need to wait and see. It's early days for us to predict, but we sort of getting a bit of insight and flavor and taste what's coming in this world and how it's going to impact our day-to-day care that we provide, and how people are going to respond to our implemented changes in the pathways, and it's coming, and it's around the corner. It's there. We are also at our Torbay Trust. We also setting up a new system of PIFU, looking at patients who remain static, who are green according to our traffic light, who we think they are stable to self-manage and self-refer and report if there are some changes, allowing them to come back to one of the clinics in 4 weeks' time from the time when they refer themselves. So it was a great pleasure, Omar, and thank you for coming, talking. We discovered a lot of things. We brainstormed our ideas. Some of them I'm going to publish. There is a manuscript that is being drafted as we speak. We will provide more comprehensive insights in the near future, and if the situation changes, we have more enhanced care that we provide to our patients locally in the Southwest. We will come back again, and we will share that expertise and experiences. To our listeners, we hope today's episode has enriched your understanding and sparked curiosity about the future of multiple sclerosis care. Remember that knowledge is power, and we hope this episode has empowered you with valuable insights in managing MS. So don't forget to subscribe to our podcast, share it with those might benefit, and leave us the feedback. Just comment below, or whichever platform you use, and listen to the podcast. So give us a bit of your insights and your views. How do you see the patient-initiated pathways and comprehensive reviews, and how can we identify the MS condition earlier by using maybe AI or machine learning or some other robotic automatization systems to help us with the day-to-day admin tasks, and also clinical decision tools that could be developed based on these platforms. So stay tuned for more episodes, and as always, stay well, stay informed, and keep thriving in your journey with multiple sclerosis. Thanks for coming, Omar.
Yeah, thank you. It's been brilliant. Thank you. It's a pleasure.
Bye for now.
Bye.